Good morning. I'd like to welcome everybody to the 14th annual Dr. Gerald Burns Memorial Lecture Series. I'm Carla Purcell, so I've talked to a lot of you on the phone. I've known you a lot of you for 25 years, and sent some emails out. So I'd like to welcome everybody here this morning. This is our biggest turnout ever, so thank you all for coming. And we're also live streaming too, so we're talking to some people at home, so welcome to you at home as well. I'm going to get out of the way, but just some housekeeping things. We will be having a little bit of a break at around 10, and that's when you'll have some coffee and sweets come out. The washrooms are at the back of the room. And I would like to take this opportunity to introduce Adrienne Malloy. Adrienne is the executive director of our foundation at the hospital, and without their support, we wouldn't be able to do this. So, Adrienne.
Good morning, ladies and gentlemen. Thank you very much. I'll be very brief. The foundation is extremely proud to be funding, again, the Dr. Gerald Burns Lecture again this year. I know that we're in for a very informative and hopefully even challenging morning. The hospital is celebrating its 40th anniversary this year and is on the cusp of a very significant redevelopment that will vault the Dartmouth General into a completely new era. In the months ahead, you will be hearing more about this and what it means for the communities that we serve. Today, though, we're here to learn. And again, we have, as Carla mentioned, colleagues from around the province by joining us by the magic of live streaming, which I don't really understand, but it works. Today, Dr. George Davis will be our MC, and he's going to come up in a few minutes. But before he comes to get us underway, I would like to ask Diane Burns to come up and say a few words on behalf of the family.
Good morning, everybody, and thank you, Adrienne, for your nice words. I just want to say that this is an amazing turnout, and I am thrilled to death. This is the 14th year we've done this. Jerry will be gone 18 years in another couple of weeks. Anyway, this is one of my favorite pictures. George was very kind enough to pull this up, and I just wanted to say it was Christmas, and the next Christmas he wasn't here. But it was at Shearwater, right, George? And was the hospital party. The wives weren't invited. So I drove him down, and apparently he never left that chair all evening. He sat there and spoke to everybody, greeted him and whatever. But he was diagnosed by then. But he actually has on the tie that he wore to Sarah's wedding in August, and he was diagnosed 2 weeks later. So it's kind of an emotional picture for me, but he, as everybody here knows, and if you have never met him, that's Jerry. Anyway, I just want to say thank you to all of you for coming, and I know you're going to enjoy this. It's going to be amazing. So enjoy, and we'll talk to you along the way.
Good morning, everybody. It's always a pleasure to be here and be asked to do this. Diane, thank you for the call. I'd like to thank the foundation for support on this. This lecture series is very enriching. Can't hear you? Wow. This lecture series is very enriching to our hospital. The Dartmouth General Hospital is unique. Jerry Burns was unique. That word cannot be qualified in the English language, as we know. That picture is in our lunchroom, and every day we get to look at Jerry. So the mental health care, this lecture was asked for by you all and on the comments, and it obviously is important to you because the turnout is outstanding. I just can't, I mean, I've never seen so many shiny faces and friendly and happy faces at this lecture series as of yet. So I'm looking forward to the education, as are you. Something about I think of memories as pillows. Pillows, in life, memories are the pillows that support us and sort of cushion our fall. And Jerry was a father, a husband. He became a grandfather. He was a mentor, a collaborator. He was a friend. All of us knew him, and he knew all of us. And his uniqueness was he knew everybody's name in the hospital. He knew their children's name. He knew the wives' name. He knew our vocations, where we came from. He was amazing. He recruited me. I became a friend of the family. I saw his kids grow, and we miss him. So our first speaker today, I have to read these. I have to put glasses on. These bios are quite extensive. So our first speaker today is Andrew Harris. He is a clinical leader for the QE2 Consultation Liaison Psychiatry Service and staff psychiatrist to the Psychosocial Oncology Service of the Nova Scotia Cancer Program. He trained at Dalhousie University. He's currently an associate professor in the Department of Psychiatry in the Faculty of Medicine at Dalhousie University. He is a clinician educator with particular interest in assessment and evaluation. The Consultation Liaison Psychiatry Service provides consultation to medical and surgical services within the metro area on patients with brain-based disorders. Please welcome Dr. Andrew Harris.
Thank you very much for inviting me today. It's a great honor. I heard a few words about Dr. Burns, and clearly he's a much-loved and well-regarded figure in the Dartmouth General Hospital. I was going to start by saying I would not be expecting to see this number of people in psychiatry turn out for a general surgery lecture, so I welcome you all. I'm going to talk today about the difficult patient, and I don't want to offend anyone by using that term, so I just wanted to sort of apologize beforehand if anyone is, and hopefully you'll understand why I've used that term and how it will evolve during my talk. But I've also apologizing for taking somewhat of a physician perspective here. I understand there are many professions represented in the room today. So again, please don't take offense, and please substitute whatever area that you work in place of the physician. It's about how we interact with patients, which I think probably would be something very close to Dr. Burns' heart. So we're going to talk today about the, in quotes, difficult patient. Here's a scenario. Maybe many of you would empathize with this. So you're running very late. The previous patient had 1 million questions, and your nurse would like you to review a chart. The resident comes up and has got a couple of quick questions, and then you get a phone call from a colleague. Just wants an opinion, but it turns into a complex consult, and here you are now walking into the exam room with the patient. Oops, excuse me. And the patient checks their watch, and there's a frosty silence. This is something familiar to some of you, I'm sure. You attempt a greeting, but your heart sinks, and a silent sigh escapes your lips. So any discussion of the difficult patient really requires that first off we talk about the idealized patient. Who are we expecting when we have an engagement with a patient? So here's some of the qualities of the ideal patient. You may recognize these or may not. So one is that they recognize the authority of the clinician. They agree with all therapy that the clinician suggests without resistance. They have no peculiarities, no particular requirements. They are trustworthy. They show honesty. They're open. They're comprehensive when you ask questions or take a clinical inquiry. They don't say anything if they're not asked. And they, of course, are very satisfied with the amount of time you've been able to spend with them and the communication that's been allotted. How many people here would have seen someone exactly like this? On the other hand, what we would regard as the difficult patient would be someone who tends to ask for more, too much, often refuses things that we suggest, declines treatments. Sometimes they're suspicious of the things that we're asking to do, questioning, challenging. They're often critical of the staff or the hospital or the larger organization, can be untrusting, ungrateful, and sometimes can be aggressive and threatening. So these are qualities that you might associate with the difficult patient, and that would, I guess, a few people would have seen. But the difficult patient, those people coming into the hospital system would get better. They have no energy to work with you in their care. And so they can be apathetic. Or sometimes the opposite of that, where they're too engaged and they're too clinging, they're calling all the time and they're wanting more than you can provide them. So these people can also be challenging. So I've set this up as a play in two parts. So here's the scene. So the curtain opens on a small and brightly lit room, and a person waits anxiously in an uncomfortable chair. A quick knock on the door, and the doctor enters, and there are brief pleasantries exchanged, and then it's down to business. So here's your role as the physician, and as I said, please include your profession in here rather than physician. So you're the physician. Your role will be to be empathetic and caring, responsible for diagnosis and treatment. You'll be an authority. You'll be knowledgeable, confident, assured, powerful. The patient will put faith in your skills to cure them, and cure them you will. So the other role here is that of the patient. The patient, you will be pleasant, compliant, succinct, honest. You're to answer questions with facts, not with your interpretations. You will accept the authority of the physician. You're to be grateful, and above all, you're to get better. So in this perfect world, in this play, the roles are complementary, of course. The obligations exist for the doctor and for the patient, and those obligations must be fulfilled in order for the relationship to prosper. But in reality, there are always tensions that exist, aren't there? The sources of tension between the clinician and the patient can include things such as moral or personal views. They can be things such as the interests of the individual versus the interests of community. Practicing in our modern day environment, there's always a question of limited resource. And when you're trying to provide care for the whole, sometimes the individual is not going to receive the care that they wish to have. Sometimes there can be conflicts in terms of confidentiality. And there can be different expectations about the model of the relationship. Some people will want a different type of relationship than that, maybe that's more classically old school. So we talk about different types of relationships within the medical setting. This would be and I don't think this would be Dr. Burns' particular style by any regard, but this is the old type of physician-patient relationship, which would be termed paternalistic. So this is a high physician control relationship, where the physician is believed to have the patient's best interests at heart. And it can have benefits to the patient by relieving some of the burden, the anxiety of the patient in making decisions about their health care. But currently, we tend not to regard this as an accepted model, and it's not the type of model that would be taught in sort of a modern-day residency program. And I don't think this is the type of model that Dr. Burns would have practiced. So the middle ground is a mutualistic relationship. So this is about equal partners. This is about a meeting of experts. It's about an exchange of ideas, the physician bringing one set of ideas and plans and the patient bringing their own. The doctor brings the skills and knowledge, and the patient brings the preferences, the values, and the experience. And then we have the consumerist view, which I'm not sure how much that is part of how we practice today or not, but it's really the reversal of the paternalistic relationship. It's about the patient in the active role, the patient being a consumer of healthcare resource, the doctor in a passive role being providing a service, a referral, a second opinion. And in this type of relationship, the clinician feels very much more disempowered. So as you can see, as I'm developing these ideas, it's not about the difficult patient, but it's about the relationship. So the real difficulty lies there. It doesn't lie with the doctor or the patient, but it lies in that space in between the doctor and the patient, the relationship. And the relationship will also always require the two parts, right? It takes two to tango. And each part of that relationship brings their own agenda. Sometimes those agendas marry nicely and sometimes they don't. But there can be expectations, concerns, conditioned responses, and attitudes that come with it. How do you usually establish relationships? Well, it's no different in the clinical setting than it is in other parts of your life. So usually relationships are developed through a process of exploration. So getting to understand a little bit about the other patient, the other person, and sharing a little bit about yourself. It's a dynamic process. You sit down next to someone at a bus stop or in a waiting room, you strike up a conversation. It's about sharing of information. So the relationship is very dependent on the needs of both parties. Some people are not interested in developing a relationship with a stranger, and so they have a low need. And other people are much more gregarious and outgoing and would like to develop relationships, so they would have higher need. And relationships in the medical setting can change with the stage of illness. As you've probably all been involved with patients through a trajectory of life all the way to death, and you know that during those different phases of caring and of treatment, the relationship can be very different. There are many different influences in the clinical realm that control or inform the relationship. Sometimes the physician's clinical practice style. So if it's a doctor-centered style or a physician or a clinician-centered style, that will often be disease-centered. The type of interaction tends to be more closed questioning. There's often a lower opportunity for the patient to express what they wish, what they want, what their needs are. But it is usually a relatively efficient style of interaction because there's not a lot of extraneous information. You can keep the time of the interview down. The corollary of that would be the patient-centered approach, and that would be more open questioning. So asking questions about how the patient is experiencing something, the symptoms or the illness or the impairment. It invites more patient participation, but it will tend to be more time-consuming, and sometimes that model doesn't fit when there's a high demand for service or for care. Other influences can be things such as communication style. So we all, as clinicians, tend to overestimate the amount of information that we are providing to the patient, because when we're actually constructing our dialogue in our heads, we're making a lot of assumptions that the person, the patient, on the other end of the conversation understands all of the background that we are providing with them. I don't know if you can think about that, whatever your specialist, especially your profession is, but there's a lot that you assume as you talk to the patient. We do make efforts not to use jargon, which is good, but we do oftentimes include a lot of background information in our sentence or the communication, which isn't something the patient might necessarily know. And oftentimes we do get into a situation where we tend to lose that ability to demonstrate, communicate empathy in an effective way. So sometimes we may seem unconcerned because we're trying to be efficient. There's a lot in the content and the process part of the relationship too. So information is exchanged, usually verbally, but there are a lot of nonverbal exchanges. So about 65% of interaction of communication is nonverbal, and it's all those things from whether you're standing, you're sitting, for example, standing by the bedside. This is typical for surgical rounds. Everybody's clustered around the foot of the bed. That implies that's a communication to the patient that we're in a rush, we're in a hurry here, we want to be efficient. Whereas sitting beside the patient's bed, maybe holding the patient's hand, right, is a much more significant communication of I'm really here, this is your time, I'm here to care for you. And you don't necessarily need to spend any different amount of time either sitting at the bedside or standing at the foot of the bed, but the one communication would be much more effective than the other. There are lots of considerations here about the patient's characteristics. So younger people these days tend to expect greater participation. That's the newer model. Older patients would have been raised in a more sort of paternalistic style, and so that's their expectation. But younger people are more informed. We're an information society. Most of them will come better informed than you about many aspects of their care. So they've been on the internet and looked things up. People in higher socioeconomic groups tend to require more information. So if there's a smaller education gap between you and the patient will tend to want to be more contributory to the engagement. And there's usually increase in participation of the patient over the course of the illness. So as illness progresses, as we get into more chronic care, tends to be more communication. And we also make lots of assumptions based on the physician, maybe the physician's ethnicity or the physician's sex or their age. As we're talking about, it's good to be a gray-haired physician sometimes, and at other times it's good to be a younger one. There's also the structural context, and this is very real in our current overburdened medical system. So some people paid on a fee-for-service type of basis, others paid on an alternative funding plan or an envelope funding, so that can influence the amount of time spent with the patient. And there can be privacy issues if the clinic is not in an ideal environment. Maybe it's noisy, or patients are clustered with only curtains between. It's hard to communicate sometimes in different environments. Also, complexity of choice. So this can be a significant burden for patients where if they have choice over some complex medical treatment versus a more simple one. So for example, this is from the cancer literature, 20% of breast cancer patients versus only 4% of colon cancer patients wanted an active role in their treatment decisions. Now this was proposed by the study that this was to do partly with sex. Women tend to want to have more choice in their treatment. Colon cancer tended to be more older males who would be more accepting of the more paternalistic style of practice. And the second part of the study, 78% of the colon cancer patients versus 52% of the breast cancer patients wanted to leave the decision up to the doctor. So, sorry. Okay, so this second part, I have structured this around things that we do within psychiatry that are to do with personality disorders, but I'm not implying that patients have personality disorders, but these are the types of parts of the personality structure that are important when we're looking at different types of patients and how we might interact with them. So some people come with more of a dependent structure to their personality. These people would tend to need to be noticed. So they would tend to be the people who would require a lot of attention from you. They tend to dread neglect or separation. This is their kind of makeup. Sometimes they have difficulties in making decisions without an extraordinary amount of advice. You may in your head have met people like this who tend to be challenging in that they take and consume a fair amount of your clinical time. Dependent personality structure tends to be a more passive style, so they will be accepting, but they will require an enormous amount of information before they accept. They tend to want you to make decisions for you, so they will tend to avoid responsibility. And they can be very easily hurt by criticism. So if you imply that they're not working hard enough towards a therapeutic goal, that might be very injuring to them. The second kind of structure would be the narcissistic structure. So anybody here has met someone with a narcissistic structure? And I'm not saying these narcissistic structures overrepresented in the physician population, but sometimes they are. Narcissistic structure tends to be someone who has a sense of entitlement. They feel that they're special. They have special values. Oftentimes they will use tactics such as pressuring or legally threatening or implying that they know more than you, or they've read more than you, or they have a friend who is expert in the area. Sometimes they'll be quite exploitive, so they can be nasty. Often they're more angry or irritable, arrogant, sometimes will overreact to criticism. And they tend to need attention, and they tend to use others in a more manipulative way to get their needs met. Another group would be those with a more histrionic structure. So people with histrionic structure would tend to always seek reassurance or approval. They would tend to exaggerate their displays of emotions. So you may well have a picture of someone you know if you worked with this type of structure. Very low tolerance for frustration. They tend to need to be the center of attention a lot, and they tend to make very rash and impulsive decisions a lot of the time. And interestingly here, they also tend to believe that relationships are much more intimate than they actually are. So they will talk to their friends about the special relationship they have with you as their carer, where you may not even really remember them from the name on the list. So the last one we're going to talk about a bit is the borderline structure. These types of people, the people with this type of personality structure, can be very challenging, but they will often have very intense and unstable relationships. So they'll be someone who you may find very difficult to interact with when they come into the clinical environment. They have a very irrational fear of being abandoned, and of course, we're all at our most vulnerable when we're sick, and worry about being abandoned by the system, the physician, the clinician would be a very real one. They tend to idealize and devalue, so they tend to, what we see, dichotomize. They operate on one end or the other of a spectrum of anything. So either you're the best clinician in the world or you're the worst clinician in the world, and there's no in between. people with borderline structure will often have a significant amount of affective instability. So they get upset very easily, very quickly, can be angry or sad. Feelings of worthlessness. So people with this type of structure often feel extremely worthless and empty. That's a major feature of a borderline structure, excuse me. And they will have inappropriate anger and will tend to be very impulsive. Included in the personality style, people will tend to sort of use more, different types of psychological constructs. This is our way of dealing with or interacting with our world. We all have these to some greater or lesser extent. Most of us have them in a functional way, but some people will have them in a way that interferes with their regular daily functioning. So projection. What's projection? So projection tends to be that you tend to see someone who is new to you, novel to you, a stranger to you, in a way that's related to someone that you used to know. So, for example, if you have an intense relationship, a difficult relationship with a friend, and that friend has characteristics that are similar to the new person, the stranger, you will tend to project onto that new person characteristics from another. So you can understand how if you've been hurt by a physician or a clinician in some way, and you see someone else of a similar age or style or ethnicity, you might project onto them that they're likely to hurt me too. Catastrophizing, this is another kind of extreme, so making a mountain out of a molehill, if you will, so taking small issues and making them into things that are much larger. Dichotomization, as I said, that's tending to see things at the extremes, so either black or white, there's no gray area. Idealizing and devaluing, so that's, sometimes you see that with troubled patients who split within a staff. So they will see a group of staff and some will be perfect, they're the greatest nurse or physiotherapist, and then others are, well, I wouldn't send my worst enemy to that person type of thing. And then generalization, which is the tendency to sort of see everything in one sort of big bland mass, that you have a bad experience at the hospital emergency department, therefore the whole of the Dartmouth General Hospital is a horrible institution, that type of thing. I find this and I reflect on it a little bit, the experience of the patient. So I spend a lot of time walking into patient rooms and seeing them in the bed, and often they'll be acutely ill with pain, or they're recovering from a surgical process, and I do have to hold myself short and think about what that patient is experiencing at the time. So patients who are ill, who are in hospital, will have a great deal of uncertainty and fear. And we tend to get inured to it, right, as clinicians. We tend to say, oh yeah, well, it's just my job, you're just another patient. But the patient experience is unique. The patient this is their life. They are the person who's, lying in the bed wondering, what does this mean? Where is this going to go? Am I going to get out of hospital? Do I require another surgery? Will there be more pain, right? So I think that's important that we do acknowledge that, and we spend some time each day reflecting on what the patient is actually experiencing rather than how we think the patient is doing. Patients who are feeling this way, who are uncertain and fearful, take a lot of nonverbal cues. So for example, as I said, 65% of communication is nonverbal. And they will often misinterpret things that we didn't intend to communicate, as I was saying in the previous example. So physical proximity, so standing across the room from the patient rather than standing beside the patient. Sitting beside the patient as opposed to standing. Physical barriers, so not having a desk or a table between you and the patient. Seated next to the bed rather than seated across the room. So these all have, these are all communications that might be picked up by the particularly vulnerable patient and misinterpreted. So I'm going to sort of wrap up here with a case. This is a case who I saw as part of my role in the oncology service. So it was a 42-year-old woman who was a breast cancer survivor. And she had been referred to me because she was having problems with treatment compliance. So when I started to take a history, I found out she'd fired 2 of her previous plastic surgeons, and she was in the midst of suing the 3rd. And as you can imagine, you know, it's a small department at the QE2, so I know all these people. So I was a bit apprehensive, you know, what's going to happen here? What am I expected to do? So anyway, she came in. She was very, very well-groomed lady, immaculately dressed, and she was very frosty. I mean, I'm a good communicator. I can usually get people to warm to me quite quickly, but this lady she was tough. She opened, I generally sort of begin to invite the patient to say, why are you here? And so she opened with a lengthy history of all the mistakes, all the complications, all of the malpractice, all of the terrible things that have been done to her by these surgeons. And she had opinions, of course, on all of the skills, the integrity of the various physicians involved in her care. And she ended that all with, I don't really think that there's much that you can do to help me. So that was the setup for the case. So I tried to open up. I sort of began with just a simple, it sounds like you've had a very difficult experience so far. Now, the purpose of this is that it's an empathetic statement, but it's really not taking a position on one side or the other. It's just acknowledging that the patient has had a very difficult time, clearly, with what's happened. It's not neutral, it's non-judgmental, and it's avoiding joining the line of bad doctors, because if you want to argue against, well, those, you know, I know these people and they're good surgeons and they have your best interest, I would immediately be dismissed as being one of them, and that wasn't going to be helpful. When started to explore, this poor lady, she'd had a life history of being hurt and abandoned by men. So she had raised 2 daughters on her own, 2 wonderful, successful daughters. She's a very independent lady. She valued control, and she had significant questions around authority. So this was a little bit of the background story as to how she'd arrived at this problem with these all-male physicians who'd been treating her. She was, of course, very angry at the way her life had turned out. So she'd struggled. She hadn't achieved what she intended to achieve in her life. And raising these 2 kids and sacrificing for these 2 kids had been a big part of her life. And so what she tended to do was project onto male physicians all of this anger that she'd accumulated through most of her life. And she accused them of incompetence, and then that anger and accusation caused a deterioration in the communication with these physicians, and then avoidance of the physician. So what we tend to do if we're confronted with an angry patient is we tend not to go in the room, right? So we avoid it, and then that just makes the person much more angry. So the approach was to try and counter that. The approach was to sort of ask and listen and be empathetic and help her to feel validated that she had legitimate concerns without really blaming anyone for why those things had happened. I attempted to make her an active partner in her treatment decisions. So I'm a physician, so I'm really one of them, but I'm not really one of them. And so I could give her validation that she had significant concerns, allow her to vent about her experience, right, to a professional, to a member of the cabal, right, the hospital group. And that really helped to resolve her feelings and resolve her anger. And it ended up, she dropped the lawsuit. I'm not saying that I was responsible for this, but she dropped the lawsuit, and she was able to go back and develop a healthy relationship with the surgeon, and she was able to get the reconstructive treatment that she wanted to have. So that was a successful intervention. But it brings together some of the points I just was trying to make about communication and about our tendency to sort of get into these maladaptive communications with patients when they come to us angry or accusatory. So just to summarize some strategies to try. When I get a very angry patient, I tend to always invite them to sit down. It's very hard to be angry when you're sitting, you may notice. Eye contact is very important, so not looking away, not disregarding, but looking attentive and looking the person in the eye. That's authentic communication. That implies, I care, I'm listening. Set the tone of the conversation yourself. So if you have a patient who's angry and shouting and screaming and using a loud voice, you speak in a measured tone. You bring the tone of your voice down, and that will always bring the patient on board with you, because we're social creatures, and we respond in subconscious ways to social cues. So if someone is being angry and you're being measured, they will always come to you. They will bring themselves back to a measured sort of conversation. Listen to the person, and I mean really listen to them. Don't just hear them, but understand what it is that they're trying to bring in the communication. And it's fine for you to then expect them to listen to you. So you can say to the patient, look, I spent this time, I did listen to what you wanted to say. Now I really need you to listen to me for a while. Don't feel bad about confronting on bad behavior. So if someone is doing things that they are not socially acceptable, it's fine to sort of challenge them on that. And of course, safety is a concern. So if you do feel uncomfortable, you should leave the engagement or ask someone to join you in the room. I'm not sure whether people would struggle with this, but it's always good to name feelings. So if someone comes to you and they're clearly angry, say it out loud. You seem to be really angry here. What is the problem? How can I help you with that? It's surprising how many times we'll go through a whole conversation. We haven't actually named the thing that's the elephant in the room, right? Anger can be a defense. It can be a mask for things like anxiety, or for someone who's struggling with a depression and has irritability. So it's good to explore it. Why are you angry is a really key question. And use your reaction to the encounter as an indicator. So we all have these kind of these monitors and tools that are within us. You can tell if someone is angry with you, right? Not necessarily because of the expression on their face, but because it starts to make you feel anxious. So use your body, your own reactions as a tool. Why do I feel anxious with this patient? And then ask the questions and explore. Acknowledging the patient's emotions is very important too. This must make you very sad. You seem very sad to me, or you seem irritable about something. Or things like, something seems to be bothering you, and I'm wondering whether, or worried that it's going to interfere with your treatment, these types of things. How do you deal with this outside of the patient encounter? Well, it's good to share experiences with colleagues. I'm sure that most of you do, but sharing them in a healthy way, not in a complaining way. Within the psychiatry resident group, we have something called a Balent group, which is essentially a process. I know this might be unfamiliar in a surgical context, but it's basically discussing how we felt in given situations or experiences, and it's a way of us processing those feelings in a healthy environment, a supportive environment. So doing that, rather than just complaining about the patient or the physician or the environment or something or other, that's usually not so helpful. Acknowledge that you're feeling things. You should feel things. If you don't feel things, then maybe it's time you take a break from patient care. And spend time reflecting as much as you can. So listening to yourself and thinking about what you're doing, and drinking. It's always good. And that's what I wanted to say today. So I'm not sure where we are for time, but if anybody had any questions, I'm more than willing to venture an answer.
How do you keep the concept of an interview when the patient is anxious and whatever, you have to go on forever? How do you control it?
Well, that's part of the art, isn't it, of practice. Something I think you learn with experience. It's something, it takes a while. but it's like a dance. It's learning to dance with the patient in a way, to move the patient across the floor to the doorway, but not in a way that they actually know that they're being moved across the floor to the doorway. So it's one of those skills that's not necessarily taught, but it's modeled by people like your husband, I think. That's how I learned it, from watching other good people do it.
I'm not sure I got that clip.
Okay. Thank you very much indeed for having me today.